to this very exciting meeting. It's exciting in a lot of different ways. It's the very first time bringing together the work of two collaborative groups, the Law and Global Health Collaboration and the Immigrant Health Initiative, so that's a very exciting thing for us to be working together. My name is Sophia Gruskin, and on behalf of the faculty involved in both collaborations, I'm very happy to welcome everyone here. I wanted to say a couple of things before jumping into the topic, and I think other people will be joining us as time goes forward. We're here, I think, because we're all very concerned about both the local and the global implications of the Trump administration's policies on immigrant health and rights. And that's really, I think, what brings everybody here today. And what we really want to do is we really want to generate a respectful and evidence-based dialogue that can help us to think not only about how we address these changes that are happening most effectively, but also how we can begin to set a research agenda, one that is going to bring together faculty and students from across the university in whatever way we can. So what we want to ask of you is, as you listen to these presentations, as you think about the conversations that we're going to have, is what are the sorts of issues that you would like to raise? How is it that we want to be able to talk about this together so that as USC, we can really help to move forward most effectively? In terms of the logistics for today, we have a little bit less than an hour. We have three amazing speakers. We have an amazing moderator. We have quite a group, I have to say, in terms of how it is that we come together. And so the plan is for each of the speakers to speak for about 10 minutes or so. Our first speaker is going to set the legal framework for where we are and what the issues are that are happening at the law school to try to address these. And then our next two speakers are going to be talking more from the health and the public health perspective in terms of what's happening here within LA and again at USC specifically. And I think we're all very concerned about how it is that we think about addressing the very real impact of these policies on people's lives. And so that's where I think we all are coming from here in this conversation. I think if you'll allow me, I'm not going to introduce everybody individually because you have people's bios on the sheet, but is that okay with you all? Is that okay? This is meant in every respectful way possible. It's just to kind of move us forward in that way. So just can I give you the floor with that?
Thank you.
And thank you, everybody. Okay.
Thank you very much for putting this together. So I wanted to start out and just talk a little bit about legally what's been going on with the Trump administration, and I think what's been happening legally has more to do with the creation of a climate of fear than it does with the law, if you will. And I put this little slide up here. Which is my only slide, but this is from the state of Arizona. This is what most people refer to as Arizona's SB 1070 anti-immigrant law, also known as Show Me Your Papers law, that was enacted by the state of Arizona back in 2010. I didn't realize it was that long ago. But this is the, I'll talk about this in a second, but this is a preamble. This is the legislature's statement of intent. Why are we enacting these laws? And so, one thing you can give credit to the Arizona legislature is, they're direct. They're not, beating around the bush. I've been practicing immigration since 1985. And when I look back over the past 30 odd years, there have been some crazy times, and one of the craziest times was in the immediate aftermath of the terror attacks on New York and Washington, and then the crashing of the plane in Pennsylvania, and the one of the after effects of the 9/11 terror attacks were increased immigration enforcement and an incredible state of fear within certain immigrant communities. And those immigrant communities were primarily Muslim, primarily Arab, primarily East African. But what we have right now, and I'll talk a little bit more about this. But what we have right now is a much broader based climate of fear, much broader. The fear is reaching into many other communities, so it's a much broader thing in some respects than what we were dealing with in the aftermath of 9/11. I was turning in my annual report to my dean last night and have to do a report of activities, and so I was going through my calendar for 2017. And it was a traumatic experience because I'm going through all of these Know Your Rights presentations that we were doing and rallies and court hearings, and I teach the immigration clinic here with Jean Reese. We were out with a couple of students out at LAX and the weekend after the January 27th first iteration of the Muslim travel ban, and it was just my head was exploding just like looking at this stuff in an Outlook in my Outlook calendar. But so that brings me to what I want to talk about. The laws have not changed. The immigration laws have not changed. What has changed is the public debate, the statements that are coming specifically out of the White House. And that has helped create this this climate of fear. I'll confess another confession. In addition to reading my Outlook calendar, I also read Fire and Fury. I spent $14 and downloaded the Fire and Fury book. And there's a lot of Steve Bannon in there. And one of the things that that Bannon is President Trump's former advisor and former head of Breitbart News. One of his things that he's been very clear about is we just need to break things. We need to dismantle the federal government. We need to shake things up. We need to scare people. We don't care if what we're trying to do ultimately gets struck down in the courts. Think, the Muslim travel ban in its first iteration, in its second iteration, and then, we have the third iteration, right now that just the Supreme Court has just, taken up on a petition for writ of certiorari, and we'll be hearing in the coming months and deciding the legality of the third, Muslim travel ban by this coming June. But Bannon and Trump's very right-wing immigration advisor Stephen Miller are basically saying we're going to do this stuff. We're going to create this fear. We're going to make these pronouncements, and even if we're not ultimately able to carry through with them because the courts might delay or stop us, we're still going to be accomplishing some things. And so some of this chaos that's and fear that's been created in the community is certainly intentional. Some of it's unintentional. Some of it is just Trump being Trump and his tweets and whatnot. But creating confusion, creating fear is something that has there's this concept former governor and perhaps next senator of Utah Mitt Romney talked about this concept of self-deportation, and that's what SB 1070 was all about. We're going to create this series of laws, checking papers, requiring landlords to check immigration status, having state officials, police officials, health and safety inspectors enforce federal immigration laws. And we're going to, basically, work in such a way to make, to create attrition through enforcement. We're going to try to make life so difficult for immigrants, technically speaking, about undocumented immigrants, that they leave on their own. And that they leave the state and go to California, or they leave the United States. And so that's very much what we're dealing with now. Some of the legal things that have happened have not been the result of legislative changes, but they have been the undoing of some temporary programs that were put into place by President Obama and then by previous administrations. And I'm speaking specifically about TPS, temporary protected status, and DACA, deferred action for childhood arrivals. And so what we had, was it a week or so ago, everything blurs together, we had an announcement from the administration from Secretary Nielsen, Kirstjen Nielsen, the new Secretary of Homeland Security, that she was ending the temporary protected status program for Salvadorans. So we have about 200,000 Salvadorans who registered for this program, I want to say, June of 2001, sometime in 2001. And they've been in this temporary program since 2001. You know, it has not been temporary, and that's a problem with the program, and it's a legitimate criticism. But we do have almost 250,000 people registered in the TPS program who've been here for 16, 17 years now. They're married, they have children, they have businesses, they're employed. They send back significant amounts of remittances to El Salvador, which is Salvador has its problems, but certainly the foreign remittances are vital to the Salvadoran economy. So what Secretary Nielsen announced the other day was a soft ending of the TPS program. People were given another 16 or 17 months to stay in the program, and then it will end. And what it means when it ends is in some respects similar to what it means when the DACA program ends for almost 800,000 young people. Not all of them are young, but most of them are relatively young. People who came to the United States under the age of 16 prior to 2012. I have to pull the web page up to double check it. But we have 800,000 people who've been in the DACA program for the past 5 or 6 years. And the DACA program, again, it's a soft ending. There's a challenge going on in the courts right now, but there's a soft ending. And so every day we have, I can't remember what the number is, hundreds, 500 people are falling out of the DACA program as their 2-year work permits are expiring. And so basically what's going to happen to the Salvadoran TPS holders, similar terminations were announced for Haitians with temporary protected status after the massive Haitian earthquake of what was it, 2010, 2011, and similar TPS protections have been announced, are being terminated for Nicaraguans, much smaller numbers relative to the Salvadoran population. So basically what's going to happen to TPS holders and DACA holders is they will go from non-citizens, immigrants with legal documents, legal identity, and they will revert back into the shadow population. They will revert back into the, if you will, the illegal, undocumented immigrant population in the United States. They will lose their work permits. Depending on what state they're in, they'll lose their ability to legally drive. In California, we do have a driver's license and a state ID card that's available to people who are undocumented. They'll lose their ability to travel. In some instances, they'll lose their ability to bank. But they will, most importantly, perhaps lose their ability to legally work in the United States. The ending, leaving DACA status, leaving temporary protected status does not result in deportation. It will be up to the Department of Homeland Security to effect arrests, start removal proceedings, and attempt to expel people, that way. Again, there certainly is a desire on the part of the administration that a lot of people will just leave on their own when they lose their ability to work in the United States. That'll happen in some instances, but in the overwhelming majority of instances, people are going to be staying here and trying to live as best as they can in the shadow population. I'm talking about 200,000 people in the Salvadoran TPS program, 800,000 people in the DACA program. That is only scraping the surface in regard to the numbers of people that we're dealing with. We have spouses, we have children, we've got, probably, 10 young people that we represent in the immigration clinic, with DACA status. I don't think any of them are married, but there certainly are, DACA people who are married. We are representing some of the, the young Salvadoran kids who've come up to the United States in recent years. Our youngest client was, 5 years old, 4 years old when she came up to the United States. Her dad has TPS, so we've won asylum for her. But she depends, and her ability to live in the United States and stay in the United States obviously depends on her dad having legal status in the United States, and with him losing TPS status in the coming year, that's going to impact people who are citizens, people who are immigrants with other types of legal status. There was this bizarre thing, and I'll wrap up, but there was this bizarre statement that came out that was released by the Salvadoran government the other week, there are a couple of bizarre statements that came out of the Salvadoran government, which is not all that bizarre, I suppose, when you think about it. FMLN president, who is not a guerrilla, if I'm remembering correctly. I think he's just a politician, not a former fighter. They basically thanked the Trump administration for ending TPS for Salvadorans, suggesting that it was a recognition of the maturity and the becoming more mature the Salvadoran economy, and it's like, what the F are you talking about? And then the other thing is Salvador announced an effort to try to send Salvadorans as they leave TPS status here in the United States to Qatar, or Qatar, as my Arab clients tell me to pronounce it, to Qatar to be guest workers in Qatar, building the World Cup stadiums or whatever, so they can be exploited with the Bangladeshis and the other migrant workers who are basically in slave-like conditions in Qatar. But anyway, so those are the main things that the Trump administration is doing. The TPS program has there's a temporary reprieve from a federal court in San Francisco that's reopened the program temporarily. The Supreme Court is going to be reviewing this case, and we expect that it probably will be shut down if the Trump administration does have the legal authority, to end the DACA program at some point. It's just a question of how they unfold it. And likewise, the TPS program, there is no legal challenge to the ending of the TPS program. That's very much a political issue. So why don't I end there, and I'm not sure who's coming up.
Thank you very much.
Thank you. Sure which, did you have slides?
And please do hold your questions, or feel free to write them down, because I think we're hearing a lot of very different presentations. You want to make sure that you write down whatever it is that you want to ask.
Oh, why is it showing up? Why did mine show up and mine not?
Maybe because I'm not in the law school.
Where's this? It should be there.
I don't know anything.
So my name is Michael Cousineau, and thank you for inviting me here today. So I want to talk a little bit about immigration and health, and particularly public health, and looking at what some of the things that are happening here, particularly in California, as it relates to health care for immigrants. I do have some data here. I'm sorry.
I'm calling IT now.
Are you? Okay. Let me go through and see what I have to say next. So it's, as you probably know, it's a fairly significant. The immigrant foreign-born population is fairly high in California. About 27% of Californians are foreign-born. About 10.3 million people. So it's a significant number of people in California that do have that are born elsewhere. Thank you. So in addition to that, of that 10.3, about 4.8 million of those are naturalized citizens, who people gone through the process, usually green cards, and then finally become citizens. Estimates, even though these estimates are sort of mushy, but the numbers are that of between 2 and 2.5 million undocumented immigrants. It's about 6% of the California population are in California. And the majority of those individuals are of low income. About 60% are estimated below the federal poverty level. So we're talking about an immigrant populations, really high levels of poverty, and all the health problems associated with poverty that many we've talked about before. In terms of access to care, which is something I'm interested in, is that, particularly among non-citizens, about 47% of non-citizens are uninsured. That's compared to about 16% of people who are born here. So even though under the Affordable Care Act we've significantly reduced the number of uninsured here in California, particularly in LA, that not everybody has obtained coverage, and disproportionately people who are immigrants, including people who are lawfully residing here, still do not have coverage. So a lot of this goes back to some of the early welfare reform laws of 1996 that created categories of eligibility. We call them qualified and non-qualified immigrants. Basically, the non-qualified are people who've been living here with a green card, but they've been here less than 5 years, and they're restricted in terms of their eligibility for both public assistance and health care. Now, we do have, even for undocumented immigrants, we do have Medi-Cal. I'll talk a little bit about that. We've had for a while an option here in California to take what's called restricted or emergency Medi-Cal. And if somebody goes to an emergency department, they're eligible to get that service paid for, and any service related to that if they have to go back, or if the woman's pregnant, she has a prenatal care, has delivery, those would all be covered by Medi-Cal. The Affordable Care Act, the Obamacare, has made a significant dent here. As we mentioned before, we've had a big decline in the number of uninsured here, including among immigrants, in part because of the rules under the ACA. Not everybody is eligible. For example, an undocumented immigrant, we have two kinds of sort of options for people to get health care under the Affordable Care Act. One is through the Medicaid program called Medi-Cal, and the second one is through the exchanges you've probably heard about called Covered California. And essentially, if you are an undocumented immigrant, you're simply ineligible for either of these two programs. In fact, if you're undocumented and you decide you want to go into the exchange, you're not even eligible to do it, even if you want to pay for the whole thing yourself. So they specifically created these barriers for people to get into healthcare. We do have other people who are eligible. The PRU-call individuals, particularly as Neil mentioned, the DACA recipients and some of the TAP families are also eligible for Medi-Cal. Now, DACA in terms of eligibility is important because nationally, the DACA kids are not eligible for Medicaid. In California, we do extend eligibility to them. Now, we do that with what's called state-only funds. That means we can't draw down federal funds to pay for the DACA kids, but we can use state-only resources. So we've enrolled, a significant number of the DACA recipients into Medi-Cal as a result of that. So we have, so that's what I'm saying. California is sort of an outlier in many respects because we are doing things for individual immigrant families and individuals that other states are not doing. But it's important and significant because we did it, but also because of the proportion of immigrants, particularly undocumented, that live in California. So it's important the things that we do that sort of keep an eye on what's happening in the state legislature on these things because they are changing. A lot of people don't know that many undocumented immigrants have private insurance. You say, really? How can? Well, actually, because most undocumented workers work. They have jobs, and many of them work. Indeed, many are self-employed, and they work for small businesses that are less likely to offer coverage. But we have large numbers of farm workers here in California that work for large growers, some of which provide health insurance. And some estimates put as many as 35% of undocumented workers actually do have private health insurance. And so some people are able to get into private insurance. They may buy it on their own. That's becoming less and less affordable, but still it's an important part of the equation. Probably one of the most significant changes was SB 75. So SB 75, there were several efforts over the past few years, actually going back to Governor Schwarzenegger, to try to expand health insurance to undocumented workers. Even the governor at that point had a proposal to include undocumented children in a health plan, in some sort of a health plan in California. That didn't pass, but fast forward a few years, we did get Senate Bill 75 passed a couple years ago that did provide full scope Medi-Cal for undocumented children. And so it was significant in terms of the number of kids. At the time, there were about 120,000 children enrolled in restricted Medi-Cal at the time, and we simply transitioned those kids into full scope Medi-Cal under SB 75. It's about 45,000 in LA, so it's really big. I'm on the board of a health center, and it made a significant impact financially on these clinics' ability to provide care to these children. About 120,000 in California, so it's a big number. Now, since then, we've continued to enroll kids into this plan, and right now, as of last August, we had about 625,000 children enrolled in full-scope Medi-Cal. It's about 5% of the Medi-Cal population represented by the Senate Bill 75. The adults are a different issue. There have been efforts to try to, legislative efforts to try to expand health insurance to undocumented adults. It's a much trickier idea because they're more expensive to take care of, a lot of people with chronic illnesses, so the estimates in terms of costs were much higher than it is for children. Children are relatively inexpensive to cover and to provide care for. There has been an effort to try to pass laws here in California that would, one, allow to enroll the adults, the parents of the kids under SB 75 into Medi-Cal, and to allow to be a state option only, to allow the adults to enroll into subsidized insurance through Covered California. But again, the cost are high, as estimates be as high as about $800 million. It's going to be an expensive proposition. But it continues to be out there. Senator Lara and others who have carried this, and others have started to turn that over to others to see if we can resurrect this. Now, I want to show this slide because counties throughout the state have developed their own programs. Here in LA, it's called My Health LA. And this is a program specifically for uninsured, undocumented adults. These are adults who are not eligible for Medi-Cal, they're not eligible for Covered California, they're not eligible for anything. So we enroll them in this. It's kind of a quasi-insurance program. It's not really a Knox-Keene full-scope health plan, but it sort of acts like it. But it's good, and you can see that the dark blue represents counties that have adopted similar programs. LA is the biggest. You see the Bay Area counties, I believe that's Riverside, San Bernardino. The bright blue represents counties that have smaller programs that are more limited to, let's say, outpatient care, maybe preventive services. And then the beige ones represent counties that aren't doing anything. So it's a little bit of a mixed bag, but at least here in California, we're trying to do something to plug the need. So where else can people go if you're immigrants? We have about 80 community health centers that are funded under Section 330 of the Public Health Act. Hospital emergency departments, not the best place, it's not where we want people to go. We have 2 ER docs in the room. They can talk about why that's not a good idea. We want them to go if that's not the only place there is. But importantly, they are covered under a law called EMTALA, which requires hospital emergencies to provide emergency care for patients when they walk into the emergency department. So it's out there. You still have restricted Medi-Cal for the adults, and people can still buy private insurance outside of the exchange. They just have to pay for the premiums on their own. So to conclude, what are our concerns? Sort of being on Neil's presentation, there's been an ongoing problem of perception among immigrants of fear that he mentioned earlier, and it is a real concern. We're doing some research right now with LA Unified School District among the Healthy Start workers who are actually interviewing, who work with families and enrolling them into health insurance. And there's a palpable increase in fear of concern among these families, even if they're here, even if they're U.S. citizens, but if they have a family member who's an immigrant, or if they have a child or a spouse, they're beginning to pull back. They're beginning to pull their kids out, not renew their coverage. They're not as enthusiastic about reapplying for Medi-Cal or health insurance. They're concerned about deportation. They're concerned about public charge that might interfere with their effort to become a full citizen at some point. And it's affecting individuals, affecting kids, and it's affecting family members. That's on top of the already level of confusion that's already out there about what people are eligible for, what they can actually sign up for. And in addition to the language and cultural barriers that persist. So in terms of, Sophia mentioned potential research opportunities, so we are beginning to work with the school district to possibly do an ongoing survey with families who have had health insurance, who are thinking about enrolling, who may be eligible, and then following them over time to see what happens. To finish, we talk a lot about in our field the sort of the public health implications of keeping people out of the healthcare system. I mean, Neil's absolutely right. The fear will result in people sort of going into the shadows. And for us in public health, that's a big concern because it's an increased likelihood that somebody will harbor an infectious disease that won't get treated. Doesn't mean they won't pass it on to somebody else. And there's a double-edged sword to that with that argument because probably have made that said yes, that's fine. That's why we should get rid of everybody and send them back home. So let's be careful with that argument. At the same time, recognize that improving access to basic primary care in a rational way is one human and as well as public health focused approach that we think is important to for this population and for the entire population here in California. So, yes. You want to do questions?
No,
yeah, we're not going to do questions.
All right, thank you so much.
All right, I'm up.
Okay. I do not have PowerPoint slides. So I kind of have I'm one of the emergency physicians in the room. Who's the other emergency physician in the room? Oh, great, great. I work at LA County Hospital. I've been there for a couple of years. I'm also a public health practitioner. I focus on refugees. And since I've come to LA, become more and more involved in advocating for immigrant populations outside of my work role at county. So, I feel like I have a little bit of a different perspective, and I think this is a perspective we probably all share, but I think is worth just articulating concretely. When we talk about immigration in the United States, when we talk about immigrant health, we have to remember where people are coming from, and what the pressures are that are leading to them immigrating here. We have to think about the driving force behind what we're seeing in the United States, but also all around the world. So recall, of course, that there are 65.3 million displaced people across the globe, right? That's probably, frankly, probably somewhat of an underestimate, the people that are facing displacement from their home. And what are the things that are leading to this? So poor governance, climate change, growing inequity between the rich and the poor, not only in our own nation, but across the world. And think about the direct line between the ways in which we benefit in the United States from inequities in the rest of the world and in our own country, right? Poor farm workers, cheap metals to be able to build the Mac that I have here so that I can afford it, all of these things. And so as we approach these issues and we get into the weeds as academics, I think it's really important to think more broadly about the trends that are pushing us in this direction. And what responsibility do we have to people in this country, and what responsibility do we have to people in other countries? What's the importance of borders? What allegiance do we have to borders, really? Do we have more of an allegiance to borders, or do we have more of an allegiance to human beings? So along those lines, let's talk about the ways in which globally we've kind of abdicated our responsibilities to the rest of the world under the Trump administration. We pulled out from the Paris Accord. We have stepped down from our role with the UN in advocating for human rights in a meaningful way. So one of the places I actually just came back from in December is the Bangladesh-Burma border. How many are aware of what's happening with Rohingya in Myanmar? So I'm a part of a team with Physicians for Human Rights doing some forensic evaluations of the injuries that people have sustained on their way out. There is a narrative of the Rohingya crisis being fake news inside Myanmar, that the international community is making this up. And a couple of people that are really allowing Myanmar to move forward with this narrative, a couple of nations, China and Russia certainly, and America's really advocated its responsibility in morally, standing up against that. And I wonder if this genocide would have happened in the same way, this ethnic cleansing would have happened in the same way under a different administration. It may have, but I don't know. Let's talk about, the increasing numbers of people coming across the Mediterranean from the African continent as well. So then we come to the United States, and some of the things that Michael and Neil spoke about. So the assault on immigrants here through reversal of DACA, TPS, the ICE raids. So just recently, you probably heard about the raids on 7-Elevens across the country. I just read a couple of days ago about a physician, a Polish-American physician, who is being detained by ICE. He has been in the United States for 40 years, doesn't speak Polish, doesn't have a completely clean record, for sure, but has raised a family here and is now at risk of deportation. And of course, under DACA, it's important to remember when we talk about the impact of these policies on health, we have a lot of health workers that are immigrants. We have a lot of health workers that are protected by DACA. We have medical students that are protected by DACA, not here on campus, but at other campuses across the country. So, what are we going to do to our public health force? What are we going to do to our health force here? And how are we going to make up for that? There's a couple of interesting places in which I think these various policies, sort of globally, locally, with regards to the environment and immigration, have come together. And one of my favorite, and I think one of the more notorious examples, is the one of the EPA ban on chlorpyrifos, or Vulcan. So Dow Petrochemical makes...
Can you speak a little louder?
Sure, absolutely. Have you guys, so those of you that were at my presentation, we gave a presentation on Trump's impact on global health earlier this year, this academic year. So there was a ban under the Obama administration that was being put forth against a organophosphate chemical called chlorpyrifos. Sorry, I have a hard time speaking out. It's known to, it's basically a neurotoxin. That's the way that it works. It causes harm to farm workers. It's been banned in many other nations around the world, and so the Obama EPA said we should really look into a ban on this. Under the Trump administration, that ban was reversed. This chemical is produced by Dow Petrochemical. They are one of the biggest donors to the Trump administration. There's a beautiful, there's a wonderful photograph that I don't have slides, but there's a photograph of Trump handing the pen for a bill that was signed to, I can't remember the name of the specific bill, but he hands the pen that he's just signed legislation with to the CEO of Dow Petrochemical. It's amazing. Recently, there was an episode where this now not banned pesticide was sprayed in the fields around Bakersfield. And there was a pesticide drift, and I want to say about 40 farm workers were affected by this. By the time EMS arrived, almost none of them were there. They all split. Why do you think they split? People are terrified. And this also is something that we've seen in our own county hospital. So there were stories early on after some of the early ICE raids and some of the, after the Muslim ban and all of those things, of patients delaying care, not coming into our ER because they were terrified of getting picked up by ICE. Initially, we weren't sure that this was statistically significant. Now my understanding is that DHS has actually found that this was a significant trend that developed after the Trump administration came into place. And then, of course, stepping away from just the immigrant population, we talk about vulnerable populations in our country. CHIP has been a bargaining chip, for lack of a better term, and everybody suspects that the tax breaks to corporations are likely to result in cuts to Medicaid and Medicare, because we'll be trying to be fiscally responsible all of a sudden. So that is my unbiased presentation about the ways in which Trump is affecting public health. And it's interesting, and I think we spoke about this as well at the last presentation that I was a part of, which is that, certainly none of us want to be unbiased, but there is a narrative that there are two sides, there are two sides to everything. And I think one of the things I'm personally starting to struggle with as a clinician and a public health practitioner is that when it comes to speaking up for my patients, when it comes to speaking up for the people that I've really tried to dedicate my life to advocate for, there kind of is only one side. And I'm just going to start unapologetically saying that. Thank you.
Hi everybody, I'm Lourdes, and I'm actually from the other campus, so it's a really joy to be on this campus. I want to thank our three speakers for their great presentations, and I actually want to take a moment to give you an opportunity, if there's anyone in the room that has an opposing view or thinks differently than our speakers have, to please ask questions or express your opinions, because it's not about us having a specific agenda. It's about us having a dialogue and a discourse around these issues. So with that, I would like to open it up for questions. Yes.
So I'm I'm with the doctor. I'm Dr. Catherine Sullivan. I'm a California licensed professional. I've worked in the county for 25 to 30 years. And what's happening now is, I mean, really, the homeless situation is really, it's genocide that's going on. And it's happening in our own city. And I'm at the point where you are, where I feel like I have to speak up as a California licensed professional who's being totally ignored in dialogue with public health. And I think that, you know, Mike, you know I've been talking to you a long time about this, that the issue of coverage, there's too much focus on coverage and there's not enough focus on access to care. And we've limited ourselves to a public health system that doesn't have the capacity, and we're not trying to build bridges to the private sector to try to get it off, to actually use all the licensed professionals, right? So they're underutilized. And one of the biggest gaps, I was just on the phone this morning with the person from LASA, because I'm really concerned about this, and I'm gonna bring this up as my discussion point. They're moving the Skid Row homeless block by block. And we know they're infected with hepatitis. We know that there's a flu warning right now from our public health. And we have public safety people and sanitation people moving them, just moving them, literally making them move, and there's disabled people in there. All their civil rights are being taken away. But worse than that, they're spraying all that infection across the city and into the gutters, and I've been calling public health, and I've been calling my colleagues at Kaiser, and I've been calling my friends in public health saying, wait a minute, if any infectious disease saw what you were doing, they would choke. I mean, it's scary to think what we're doing, and I really believe that we're at a moment now where we have to integrate the public health and health service delivery system, because when you send them to the ER, they discharge them to the street. They literally just discharge them to the street, and they're sick. They're critically ill. So what I want to talk about today is that the system's broken. The Medi-Cal system, and I don't know if everyone understands this because I'm just found this out as of January 1st. The Medi-Cal system only covers social service. The Medi-Cal system does not cover health services. All the health services have been shifted into managed Medi-Cal or managed Medicare, which means all the health services are HMO. And if they show up in your ER, you have to take care of them, but they end up in the street. So that's...
Well, I can respond a little bit
Could
to
you
that.
guys come over here?
Yeah.
So our speakers, if you could just come over here for a minute, and Parveen's gonna respond to that.
Yeah,
And
no.
Parveen, can you tie that to whole edition?
Yes, absolutely. So, I can certainly share, I certainly share your frustration, and I think, as an ER doc, when we see patients that come into the emergency department and require longitudinal care, primary care, specialty care, it's very challenging because, as you said, the systems are very challenging to navigate. For us, speaking of immigration specifically, I think, even the patchwork of care that Michael was talking about with My Health LA and the crew call coverage for people that are DACA recipients and TPS recipients, even identifying patients that will benefit from that in a safe way in the emergency department, and then building those connections, via legal services is challenging. How do you ask patients about their documentation status? The short answer is you don't. So identifying vulnerabilities in a safe way is really challenging in the emergency department, and that's an active area that we're working on. We actually had a conference at the Wellness Center with the Office of Immigrant Affairs and some other folks in the county, where we started to explore how we could make sure that we're identifying patients that that will benefit from these connections.
So one idea though that I heard was that there was going to be looking at transitional care units, right? So you could have transitional care units so that you don't discharge from the ER to the street, right?
Could we maybe have you guys discuss this
Okay,
a little bit
let's do that.
later, so
That's
that
fine.
because that's a really big issue,
Yes, a
and
huge
I
issue.
think talking about the systems is really important.
Right.
But I want to give an opportunity for others who might also have questions or issues you want to raise.
Mhm.
Okay, so on NPR and other places, but NPR said this also, that DACA was either passed illegally or illegal, and I cannot understand what they mean by that. Do you have any insight?
I mean, the basic argument is that when President Obama created the program, that he did not have the authority to do that in the absence of congressionally enacted laws. And you know, there has been a question about that, and there has been no definitive you know, court ruling on that. It's a practice that has been used by administrations going back at least to the Eisenhower administration. You know, albeit with smaller numbers. So, you know, I think it's perfectly legal, and you know, as do most, you know, immigration, you know, scholars.
Yes.
I wonder if you could talk a little bit about the, more specifically about the Trump administration policies on the UN and on the UN issues around health and the law.
Sure. You know, certainly funding to UN agencies has declined. One of the biggest assaults on health has been the reversal, so the re-implementation of the gag rule. So essentially, any agency globally that even speaks about abortion services can lose funding in the U.S. And you know, the budget details, it's really hard to keep up with all, frankly for me it's been really hard to keep up with all the budget details, but certainly proposed budgets from the Trump administration consistently cut global health funding pretty dramatically. And this is unfortunately in the context of growing need globally, shrinking resources across the board, so it's worsening the problem.
Any other questions? One thing that I want to point out as well is something that, you know, I think you've all hinted at, and that is that, you know, it's not just like Hispanic immigrants, because we, living in California, we tend to think about that, but we have a number of refugees coming from other countries, as well as people from Africa and, you know, and other countries as well. And so we need to think in much more broadly about what are some of the issues that are impacting all of these populations that are immigrating into the United States. And, you know, just some of the things that have been raised, I think that one of the major concerns I think that we've been talking about is how our federal government has really been creating such a climate where the discourse is really one about creating confusion, fake news, and sort of like people don't know what is the right direction. And somehow I think that all of us who are interested in these issues need to be at the leadership position of driving that discourse in the direction that we want to see it. Because if not, that's how the checks and balances of this country, which are there, constitutionally there for us, are not then you know, utilized in the ways that we need to. So we just have yes?
No, go ahead, finish it.
I wanted to give our speakers as well, unless there are any other questions. Yes?
Quick question. I teach children in emergencies at Tech. My name is Marian Garzonda. And I was wondering about children of undocumented parents who are being deported. They live in absolute fear and anxiety and depression. My question is there anything that is happening for these kids in terms of providing support, or is there anything we can do as this collective brilliant brains in this room?
The schools are beginning to do something. So LA Unified has a program to identify these children and to theoretically reassure the parents that they're not going to be deported. Now, they can't do that completely, at least they're trying to explain to them what their rights are. That's the first step. They unfortunately don't have enough resources to actually put it on the ground, the assistance that are going to be needed to help these families. But they are very concerned. The teachers, the counselors, the principals are coming to the district saying that these families, that some kids aren't coming to school, that there's just a tremendous amount of fear in certain schools in particular. So they're trying to deploy some resources in some of these high-risk schools to deal with this. But this is sort of a new thing. I mean, it's exactly new, but I mean, it's become much more acute in the past few weeks, past few months.
And we've been seeing at LA County, for example, a reduction of about 30% of the entire population that is coming in. I'm going to give Niels just a second to respond to that as well, in terms from the legal perspective and your legal clinic.
I mean, the reason we have 11 million undocumented people in this country is not because they don't know what forms to fill out. There is nothing in the law that creates a path to legal status for most of them. Having a kid, doesn't give you the right to stay here. So all we can really be doing, in the schools and in the hospitals and elsewhere is know your rights education. And I mean, it's sort of I get tired saying it. I was saw it pop up on my calendar over and over last year, but that's really all we can do is encourage people to get consultations. And there might be some path to legal status, but for most people, there is not. And there's nothing we can do about that until Congress changes the law.
So Sophia, and then over here.
Yeah, I have a question for all three speakers, and you're all three doing really amazing work, all three of you, and it's hitting at this issue from very different places. And I have kind of, if you each could say, and you could take the other questions first, but if you each could say, what information, because I'm thinking about the research agenda piece of this, I'm thinking, like, what information do you wish that you had that you don't have? Like, is there some question that you have in terms of where you think, we don't have this data, but if we could have this, this would be really useful to us? Is there anything that you could help to kind of move this conversation? And then also, when you think about your priority populations, what do you think is kind of the key issue you would like to see kind of people address and people advocate for? That's kind of my question to all three of you, because I think that might just really help us to begin to think about this.
I mean, I can address part of that. I mean, I think one of the things that we see, and it's certainly emphasized here in terms of people having contact, whether it be with an emergency room or a community clinic or whatnot. But we have clients coming into contact with all sorts of different types of governmental entities. Whether they be libraries where we've done naturalization and know your rights workshops or community health clinics or whatnot. And it really is just that is a source, that is a resource for a lot of people. People go to the library, people go to the doctor, people go to the dentist. People go to school, obviously, and just sort of trying to know more about what resources are available to those entities, where they're getting their information, where are teachers getting their information, where are school nurses getting their information, so that there can be some sort of effort to at least get reliable information out that will address some of the fears. And the fear's not going to go away because there's reason to be fearful. There's good reason to be fearful, but you just need to to plan.
So one, I wish we had better data on the undocumented population. It's very difficult to study this, to even identify them, find them, build the trust and confidence you need to collect data, and then turn that data into something useful. But I think if we had that, we would be able to make a better argument, at least to a certain percentage of the population, that there's a reason to have a better approach in terms of immigration policy. The population I'm most concerned about, Sophia, is the young adult population. I'm concerned about everybody, but I'm talking about the 18 to 35-year-old people who are, in the community college system, graduated from high school, just entering the workforce, and the impact that they're having not only on their families but also on the economy here in California. Mm-hmm. So I think that's the population if I had to prioritize, that's what I would.
Mm-hmm. I think what I would really like to know, and I think this is going to require really close collaboration with the communities, the immigrant communities themselves and the undocumented communities themselves. I'd like to understand what it is we can do as healthcare providers in the emergency system to make them feel safe accessing care. It's a tough conversation to have because we can't promise safety, actually. What we can do is promise that we will do everything in our power to keep them as safe as possible. And so I think we need to work on those mechanisms. And I think community-based participatory research is a really important approach to use in this specific context. From an advocacy perspective, I think that some of those issues I was talking about more broadly, I think we need to redefine the tribe. I think a lot of this comes down to perceptions of tribalism. This is my tribe, this is the American tribe, this is the British tribe, Brexit. There's this nationalist conversation happening around the world. We need to start breaking that down. And that's going to be
really difficult conversation.
We have time for one more question.
Yes, I just wanted to share a quick resource. My name is Paula Hedges-Brown from the School of Social Work, and I'm working in a project at the Mexican Consulate where we started a mental health program, and we provide free services for Spanish-speaking immigrants from anywhere. They can go to the consulate and they're going to receive prevention and early intervention services up to 12 sessions. And if it's more severe, we've developed partnerships with mental health providers in the community that are actively receiving people who are undocumented and uninsured for their programs to receive more higher level of care, and including medication and psychiatric support as well. So I have some brochures here in Spanish, but I can give you my card and I can send information in English as well. I just wanted to make sure everybody knows that there's something.
Thank you, Paula. And we'll squeeze in one very last question.
Even though I'm a Democratic voter, I'll speak kind of for the other side as best as I can, because there's nobody here apparently from the other side. While those of you who are attorneys and physicians, I understand your total devotion to anybody who is your client or anybody who is your patient. I wouldn't have it otherwise. But dollars are always limited. I mean, there's people that do have the idea of, yes, I'm a coal miner with black lung, or I'm a fisherman with hands that don't even operate anymore because I was fishing in a boat off the Aleutian Islands, and I have limited use of my joints at this point, who would like to have their own medical care. And as one of the few people in the room who has probably crossed a lot of borders illegally, just for Congo alone, which used to be called Zaire, I've crossed illegally into Congo from Uganda, I've crossed illegally from Rwanda, I've crossed illegally from Zambia, I've overstayed visas in Zambia and in Mozambique. I can't imagine that the outcome for me would have been a very nice outcome. People do consider their borders important. People do consider their own people and their own tribe very important. The area that I used to work in South Sudan is now in tribal warfare. Once again, people consider their own very important. And even the people who are in the United States, when they talk about what's important to them, they say family, and they mean their family. They don't mean somebody's family in northern Idaho, or they don't mean somebody's family in western Wyoming. They actually mean their family. Human beings can be very selfish and always have been. And the people that you're advocating for are no less selfish than the other side that's looking so ugly at this moment.
Thank you. Do you guys, thank you for your comments. Do you want to give us some parting words, because we actually are right at the time?
10 seconds. I worked in Boston for 8 years, and there's a huge opioid crisis there, and it's all folks that are white Americans. Sorry. Yeah, so just saying that, certainly I hear you, there are completely vulnerable populations in the United States that need to be addressed, and this obviously is an Immigrant Forum. I don't think we got into that in the same way. I do think that one of the very common tactics being used is kind of promulgating this narrative that there's an us versus them. That somehow we are pitting CHIP against the immigrants. We are pitting the opioid crisis against, the refugees, or whatever the narrative is of the day. And again, I think we have to step back and as healthcare providers and attorneys and just as professionals, we have to re-educate people that it's really not a zero-sum game. There are a lot of commonalities, and that potentially some of the decisions we've made legislatively, nationally, could have been made in a way that could advocate for all of the people at the bottom, of which there are many, instead of the very few people at the top. Those are my parting socialist words.
And on top of that, in terms of borders, the Ebola virus did not recognize borders. The hepatitis A virus does not recognize borders, so maybe we should, and I agree with you
Yes,
to some
on
extent, but at the
those
same time, we need
communicable diseases,
to understand that.
totally agreement.
Right.
And I would just say, when you look at the 11 million people, who are in irregular status here in the United States, that is in part, perhaps in large part, as a result of intentional national policies. That is not something that just happened because individuals cross borders illegally. The United States, we in quotation marks have allowed it to happen, have encouraged it to happen in some respects, because there are benefits to having a workforce, a disposable workforce like that. And so, I don't think, that the same doesn't necessarily apply to the situation in, Mozambique or Sudan. The situation we find ourselves in terms of undocumented immigration in this country is the result of, intentional, policies in some respects.
Well, thank you so much. I just want to give you some parting words. I think that in this era that we're all very challenged by whatever your thinking is, I want to really encourage you to really get engaged with the system, run for office, get engaged in the research and in the work that you're all doing, and really become an active participant in your democracy. This is our country, and we need to make sure that it is run by the values that we all embrace. So thank you so much for being here.